So a big, huge welcome to this webinar. It has been a few months in the making, and we're really excited to welcome you to a webinar titled From Reactive to Proactive. We're looking at the lived experience and the nursing role in multiple sclerosis care. I think the key part for me is that this webinar is a joint partnership between MS UK Charity, the Royal College of Nursing Neuroscience Forum and Neurology Academy. So just to introduce myself, my name is Ruth Stross. I am Head of Nursing with Neurology Academy. I have a background in neurology. I'm also on the RCN as a Neuroscience Forum committee member and a trustee with MS Together. Joining me today is, and I'll let them introduce themselves. So over to you, Jonathan.
Hi everyone, I'm Jonathan Beebe. I'm the UK Professional Lead for Neuroscience and Learning Disabilities with the Royal College of Nursing. Great to meet you all today.
Ryan.
Hello everybody, my name's Ryan Jones and I'm a helpline and information officer working for MS UK, and I'm going to be talking a little bit about the work that we do to support the MS community, but also my own lived experience of MS and some of the notional experience of supporting the newly diagnosed members of the community too.
Thanks, Ryan. Simon.
Hi, I'm Simon. I live with MS for the last 10 years and I volunteer with MS UK. Yeah, I like to try and get up to as much as I can. That's me.
Thanks, Simon. Sarah.
Sorry, I'm the MS specialist nurse in Torbay in South Devon. I'm also a member of the committee for the UK MS Nurses Association as well.
Thanks, Sarah. Yeah, so a big thank you to our panelists and speakers for joining us today. Thank you very much to you for all joining us for this session. Just a quick overview of the kind of aims and objectives. I mean, in essence, we really want to showcase the change in MS care from 20, 30 years ago to what it is today, and the complexities, but also the excitement and ideas for the future. So we really want to enhance the knowledge and expertise of all healthcare professionals within this webinar. So yeah, thank you very much for joining us. This is how we're going to break down the sort of 75 minutes. So we're going to have a quick update from Jonathan on the RCN Neuroscience Forum. And then Sarah's very kindly agreed to give us an overview of what is MS. Then a very big whistle-stop tour through symptoms by myself, and then a really useful and helpful session from Ryan and Simon looking at the personal insight. And then we hope that we'll have a little bit of time at the end for questions from yourself. If we find that we run out of time and there's a lot of questions, then we will be able to answer them online. So they'll be available on the website. So please do start from now. If you have any questions, we won't answer them during the session, but we will answer them afterwards. Just quickly, there's a health and wellness on demand session. We have this online, so you can sign up. It has 9 modules. This is education for you. This is about looking after ourselves. And we have other on-demand webinars. As I've mentioned, this will very much, this webinar that you're listening to now will be available online. So if you have any colleagues that might find that helpful, then please do let them know. So without further ado, I would like to hand over to Jonathan just to give us an update on the RCN Neuroscience Forum. Thank you, Jonathan.
I won't keep you long because I'm not what you're here to listen to, really. But yeah, I just wanted to share some information with you about the Royal College of Nursing and the work of the Neuroscience Forum in particular. So the Royal College of Nursing, we're a member-led organisation. We have around 500,000 nurse members across the UK. We're the largest UK nursing organisation. It's really important to us that we are representing our members. So it is looking at opportunities like this to hear from you and to support what matters to you. I think a lot of people know about the RCN through our trade union side of things. We'll have reps that can support you in the workplace and things like that, but you may not be aware of our professional side and how we support work in supporting your professional practice. And a lot of that work comes from the forums. So the RCN Neuroscience Forum, we have we have exactly 3,002 members, we know, because we counted the numbers the other day. And that's brilliant. That means that we are representing for sure 3,000 members that are working in the area of neurosciences. It also means when we get, for every 1,000 members, we get a seat at the RCN's Congress, which means then we can represent neuroscience nursing at Congress, the largest nursing event of the year. Each forum is governed, I suppose is might be the right word, by a steering committee, which is made up of 7 appointed members. The applications for membership are open now, I believe. If not, they will be very soon. And we have one space on the Neuroscience Forum, but there are spaces on other forums too. So do look at the RCN website for appointments to forums and how to get involved. So if you were interested, you would submit a brief about yourself and why you would like to be involved in the forum. If it was for a forum I oversee, I would look over that with the forum chair, and we'd shortlist people and we'd interview people and we'd appoint people, sorry, largely based on what the ambitions are of the forum going forward. It might be that we want to make sure we've got a good mix of people. So at the moment, we've got nurses with expertise in MS, Parkinson's, headache disorders, stroke, epilepsy, and a wide range more. So we're making sure we cover a broad range of neuroscience practice. We also try and make sure we've got representation across the 4 countries of the UK, so we can accurately reflect membership there. So yeah, if you're interested in applying, feel free to drop me an email. I can book time with you to talk through it further, but do apply. The work of the forums at the moment is led by what our members want to do. So there's some work we're doing at the moment in regards to developing competency frameworks for headache nursing practice. We have already an established stroke career framework. So we're doing an evaluation of that to see if it's useful for practice and does it need updating. If you've got an idea of something you think the forum should look at, again, send me an email with your suggestions. I'll take that to the steering committee and we'll see what we can do. If you're great to get the RCN behind that, get in touch and I'll see if we can support the work that you're doing in any way. We have a strategy day once a year where we plan what we're going to be doing for the next 12 months. And I think central to our ambitions at the moment is creating a community amongst neuroscience nurses in all areas of practice. We feel that neuroscience nursing isn't recognised enough, that people don't know what your career paths might be. So we're trying to demonstrate that, you know, we're all connected and we work together and there is a community of us there. Really pleased to be supporting events like this. This event came about because we were reviewing the RCN Learn webpage on multiple sclerosis. Ryan kindly helped to rewrite that, and I've had further input now from Ruth. So it's looking at where can we tap into expertise to make high quality resources for nurses to use. And we thought through it whilst we did that, wouldn't it be great to do a webinar that supports nursing practices? So very keen to collaborate with others and look at what we can do to benefit nurses. I'm going to stop talking there because you don't want to hear much more about me, but I'm really pleased to be supporting this event.
Thank you, Jonathan. I think it's really exciting, as you say, it's all about collaboration. I think this is great that we're all here having this conversation. So it's absolute pleasure to hand over to Sarah, and thank you so much for coming and speaking here today, Sarah. I know you're hugely experienced, and I think you're also a committee member for the UK MSSNA, and I can let you go into that in a bit more detail. So over to you, Sarah. Thanks.
So I'm going to do a bit of a whistle-stop tour around what MS is. It's my disclosures. So really going to look at what the biology of MS is, what it looks like on an MRI, different types of MS, how prevalent it is, myths busting some bits and pieces, its history, how it's become more proactive over the last 100 years, different causes and genetic factors, and how we currently look at treatment. So MS is disease, it's an autoimmune disease that affects the central nervous system, predominantly the brain and spinal cord. And this can also be the optic nerve as well. That's going to be on the new criteria for diagnosis. So basically the immune system mistakes the myelin, which is the fatty covering of the nerve, for something that shouldn't be there and starts stripping it. And that leaves the scars. And these are plaques or lesions. And they call the sclerosis. So multiple sclerosis means many scars. So the ongoing damage to the actual nerve fibers is what causes a lot of disability. And it causes a whole range of symptoms. Anything that can be innervated can be affected. And Ruth will go into symptoms in a lot more detail. This is the kind of thing we see on MRI. So you can see these white areas of demyelination, these plaques. And there are certain places where MS plaques like to sort of hug round. So around the ventricles, as in the middle picture, and down the spinal cord, and they can be a lot more subtle. Predominantly 3 different types of MS. The biology is all the same. Its presentation is how it gets classified. So the most common type is relapsing remitting MS, and it's about 85% of new diagnosis. And this is where people will have a relapse, they'll get better, they'll have another relapse, get so much better, another relapse again. And this used to be how it was managed in the early days. And if when there were treatment available, they would escalate it as people had more and more relapses. We now treat it the opposite. We start with the higher treatments first. Relapsing remitting MS can become secondary progressive MS, and primary progressive MS you're diagnosed with from the outset, and that is just ongoing deterioration. In the world, there's approximately 2.9 million people with MS. In the UK, there's around 150,000 people, and that's about 1 in 400. And each week, and about 135 people are diagnosed. Most people are supposed to be in their early 30s and 40s when they're diagnosed, but when we go back through their history, often the signs of MS start a lot earlier than that, and a lot of them experience them in their pre-teen stage. 71% of people diagnosed are women. It's roughly 3 to 1, women to men. It's the most common condition of the central nervous system that affects young adults, and it's a lifelong condition, but it's not a terminal illness. You do not die of MS, you die with it. And everyone's MS is really different, so no 2 people are the same. So we can generalise treatment, but we can't always specify it. It has to be individualised. Common myths around MS, that it's infectious and contagious. It isn't. It's an autoimmune disorder. It cannot be caught from someone else. Inherited, the jury's still out on that. There is some genetic component somewhere, but no one has isolated it as yet. I'll end up in a wheelchair. Nobody knows. With the treatments we have now, it's unlikely that you will be wheelchair bound if they're started early enough. People with MS can't have families or work. Lots of MS patients are productive members of society and have children just like everybody else. There's nothing you can do about MS. You can modify lifestyles, you can have treatment, it can be managed. Years ago, this was the case. There was no treatments available. MS only affects the body and not the mind. We know that there are lots of problems with cognition, word finding difficulties, brain fog that go alongside the physical symptoms, and fatigue is probably one of the biggest symptoms people have. You can see all the symptoms of MS, you can't. And I'm sure Simon and Ryan will tell you more about those. And Ruth will talk more as well. Exercise is bad for people with MS. It's not. Years ago, people were told not to exercise, but now it's now part of lifestyle changes. It's good for neuroplasticity, it's good for brain health, and it's all research-based to support that. MS history. I think the Vikings had a lot to do with it. There's a really high prevalence in the Orkney Islands. I think it's about 170 people in their entire community, which is not very big at all, are known to have MS. And they think it may have come from the Viking genes when they spread across Europe. There are cases recorded as far back as the 1300s, which could have been MS. And the first person who was actually diagnosed with MS was one of Queen Victoria's cousins. And this is a gentleman who named it. This is Charcot, who is a physician in the 1800s. And anybody who works in neuroscience will probably know his name from a lot of other neurological conditions. In the last 100 years, things have sort of started a bit slowly and then got more proactive as we've gone along. So in 1916, James Dawson discovered myelin damage, and that MRI with the fingers on the ventricles are called Dawson's fingers after him. Steroids were first looked at in 1969. MRIs were first used in 1977, but it wasn't until 1981 that they actually started doing them in MS. And now they are a mainstay with our diagnostics. 93, the first interferons were approved for MS. So before this, there were no drugs whatsoever. And we now have about 14 drugs in all that we can offer patients. And we've now got drugs for secondary progressive MS and primary progressive, which we never had before. The McDonald's criteria, which was introduced in 2001, is the way we diagnose MS. And we're now on its 5th revision in 2024. And as we learn more and the imaging gets better, we're diagnosing people earlier. And therefore we can treat them earlier and stop that disability happening over time. As I said, no one knows what the causes of MS is. There may be factors such as vitamin D deficiency. We know that further away from the equator you get, the higher the prevalence of MS. Some people with MS wonder if they've done something that could have caused it. No, you couldn't. You can't actually injure yourself and cause MS. Epstein-Barr virus is a possible trigger, but no one knows how all these triggers come together to actually cause the disease in the body. We know there is some genetic risk, but no one knows exactly what the link is. This is my family. My husband had MS. So my children have got a 1 in 48 chance over their lifetime of actually developing MS. But the lifetime risk in the general population is about 1 in 330. So for those of us who have got nobody that we know, that's our risk. When we're treating MS, we have disease-modifying treatments which we use to manage this. Not everyone is eligible for them, and some people choose not to take them. They're very powerful drugs, and they stop new lesion development. We manage symptoms with a range of drugs, so whether they're pain relief or spasticity, we've got a whole slew that we will use. Steroids, which used to be the main way MS relapses were treated, we don't use as much now because they can have lots of different side effects. And if people are getting better, that means that the relapse is getting shorter. And steroids don't change the outcome. They will only shorten the relapse episode. The biggest thing that we promote with our patients is lifestyle and exercise. So healthy living, healthy lifestyle, whether that's mindfulness, meditation, yoga. There's all kinds of things that people can do to help themselves and to reduce their risks of their disability getting worse as we go. And just to promote, on the 30th of May is World MS Day, which is where they try and pull together lots of different stories from people all around the globe with MS. And if you Google it, there is a website dedicated to this. And there's lots of really inspiring stories about people with MS and how they cope from their day to day. And hope if you've got any questions, you can put them in the chat.
Thanks, Sarah. Yes, absolutely. Please start putting your questions through. It will be really good to sort of build a bank of things that we can discuss after Ryan and Simon's session. Thank you so much for that, Sarah. A huge amount of information in a short time. So I really appreciate that. So I'm just going to go through symptom management and a couple of other things. And obviously this is a very top line. So please do look online in the charity. There's the MS Trust, the MS Society, MS Together, Shift MS, MS UK, obviously, and then others. And I really would recommend that you signpost patients to these professional forums and professional places for information, because I think sometimes that can be unhelpful when they seek help elsewhere. So I'm just going to go through some of. So I have quite an interest in looking at more of the kind of invisible symptoms, and I just thought this survey might be quite interesting. I'm not sure if it might be shocking for you, but I found this quite I don't know, quite concerning when I first read this, that actually more than 33% of people have hidden their condition from others, and more than 10% admitted they had kept it from a partner. Now, I can't imagine living with someone that you haven't disclosed that you have a long-term neurological condition. That must be incredibly difficult. And 33% had kept it from at least one person in their family, and 60% had not shared their diagnosis with colleagues. And I know we're not particularly covering that today, but that is a huge area. I think Ryan and Simon might well touch on this later. But for me, obviously, a large part of the MS nurse role is about, and all of my colleagues that I work with in the MS entity is very much about keeping people in work and supporting them in the work environment. So the invisible symptoms, particularly cognitive impairment. So we do know that around 46% of all people with MS will have some degree of cognitive impairment, and as that becomes more progressive MS, then that increases. And these are some of the huge impact on their day-to-day life. I won't go into it in detail, but you can imagine that, you know, for example, the higher rate of divorce, you know, the cost implications of that, and the impact of them within their family, if they're bringing up young children, if they're trying to juggle work, and just feeling like there's less autonomy, and they often, we find that people will start to step back. I think the problem with cognitive impairment is that often we don't know, we're not very clear on what degree of impairment people have. And that's partly because in the UK, we don't routinely test people on diagnosis. In some countries like Canada, they have baseline psychology testing, and they track change over time. And that's incredibly helpful to inform around work, and just to have that conversation to support people to stay in work, and to support people within their family, and in any capacity that they feel they would like that help. So something invisible like cognitive impairment, and other areas. So we know from the evidence that cognitive impairment and depression, anxiety, so all of the mood disorders, can mask very similarly. So you can find that someone might present with what you think is cognitive impairment, and actually it's more of a mood disorder, and vice versa. Some of the other invisible symptoms are around chronic fatigue, and obviously sort of sensory disturbances. And I quite like this image this kind of describes that iceberg, that there's a lot going on for the people that we are seeing, the people that you see in the community and on the wards, and in whatever environment that is. They will present, and often I haven't got the comments on here, but there's so many comments, but you look okay, you know, you look fine, and frustration around why people can't do things at work. So there's a lack of understanding around the cognitive fatigue. And obviously there's more visible symptoms that that can impact work and can impact everyone in their day-to-day life. And actually, I think one of the things that we all have, the challenges for the invisible symptoms, is the quality of life impact, kind of diagnostic difficulties. So we're trying to, as we've said, if we're not really testing and we're not having baseline assessments, then it's quite difficult to actually support people in what might be a bit more helpful and structured way. And as we know, the fatigue is the huge impact. And one of the programs I'd highly recommend is the FACET program with regard to that. Now, I know this does in no way summarize the complexity of the symptoms, but this gives you an idea of just some of the symptoms that are experienced by someone with MS. And I'm sure we'll go into a lot more detail with Simon and Ryan within their session. But there is a huge impact, and I think the complexity around the symptom management is improving. So we have much more of an idea around medicines management. So this is a Venn diagram that I just sketch in pen when I see people for the first time at diagnosis. Find it really helpful. I literally draw these 3 circles and then the lifestyle choice in the middle. And I do this because I want to describe to them what disease modifying therapies are, what relapse management, what symptom management, and how they intertwine and what they are, so that it's much more of a visual understanding. And a colleague of mine very kindly drew this to reflect and kind of how they interact. So it is complex, and obviously things like disease modifying therapies, as Sarah has said, have much more of a long-term effect on a person's MS, whereas symptom management is about managing the symptom now. So priorities in MS symptom management, it's very much around sort of obviously education, when people report symptoms, and we obviously like to look a lot around prevention, and making sure that there's a safe communication space, coordinating multidisciplinary care, which is really complex, as you can see from that image. And I think one of the things that we're not quite there, and maybe we will touch on it today, but one of the areas is we are starting to talk about bladder and bowel, but I'm not sure that we really have that open conversation around sexual dysfunction. But that is definitely changing. I know that from speaking to colleagues, and we are starting to have that conversation. I think a lot of it is around our confidence to be able to ask the questions and have that conversation. This is to show you the exciting changes that have happened. There's a lot of work coming out of Nottingham around cognitive rehabilitation and vocational rehab. So there is much more structured programs that are being brought in. There's new symptomatic medications that we've seen for overactive bladder and spasticity. There are symptom tracking apps, which I really recommend patients use, and they can bring that evidence and they can tell me what they've been up to, and it kind of gives them a real reinforcement and encouragement that they are doing what they had hoped to do, and that's at whatever level they are able to. And obviously that's managed through working with our colleagues across the neuro rehab team, physio, OT, etc., who are much more experienced in that area, and remote monitoring. And I know that Sarah works with a colleague who very much looks into that. I'm not really going to go into this in a huge amount of detail because Sarah's touched on it already, but there is relapse management. As I said, that's one of the 3 circles. And that very much feeds into the disease modifying therapy treatment. And if we are not aware patients having relapses, then we're not aware that they might need to escalate the treatment. So one of the things, if someone is presenting at hospital or in the community, that's absolutely key is to feed back into the MS services so that we can make changes to their treatment. We can decide whether it is initially it's a urine test to check that there isn't just an infection, and then if that has been eliminated, then it is treating with steroids, and then it's monitoring and making sure that they're fed back into the system. And they definitely have a local MS team that is looking after them. I think one of the things that is key is this holistic approach to care that we are trying to form within our teams. One of the this paper I was involved with quite a few other colleagues across the UK was looking at MS care integrating advanced therapies and holistic management. So please do have a look at that online, and it's around what we need to be looking at in priorities to support people, and a lot of that is around social connection, and I think that's very much coming through the benefit to people having that social connection. And I know MS UK will talk about they provide, but also Shift MS have this buddy network. MS Together offer counselling service. MS Society and the MS Trust also offer, you know, other services. So I think it's pointing people into this place where they can actually have that connection, just with friends, but also maybe across the MS community. One of the papers I'd really ask you to read, it's really interesting, is one that came out in 2022 from the World Health Organization around optimizing brain health across the life course. It's very interesting, and it very much talks about how many, it talks about the kind of social determinants of health, and it talks about brain health, and it just talks about how we can support people with their physical health, healthy environments, safety and security, learning and social connection, and access to quality services. And I just think that can help inform what we're looking at locally. So I can't go into this in too much detail, but there is a paper that was that came out from Gavin Giovannoni and his team looking at brain health time matters. And these were kind of some of the key recommendations across both those papers, and has come from many others. So looking at the sort of if we prioritize brain health and we advise patients from diagnosis, we can look at the cognitive reserve, avoiding toxins with not smoking, with advising people to give up smoking, with regular exercise, whatever that looks like, at whatever level. And I think that's key to involve the neurophysio within that discussion. There was a paper that came out recently looking at the Mediterranean diet and the kind of anti-inflammatory effect, and also absolutely quality sleep. That's vital for cognitive function and fatigue management. So I guess future directions is around in symptom management is we are on the way there, is looking at personalized medicine, targeted and early treatments that Sarah was mentioning earlier. We're looking at neuroprotection and remyelination. We very much are working towards collaborative, holistic, multidisciplinary care, and that multidisciplinary team is evolving very often. With every few months that there are discussions that we are building services, we're building collaborative joint clinics, digital health and remote monitoring, as we've touched on, and also we need to have more of a focus on progressive MS. I think as we've had the DMTs, it's great that we have the disease-modifying therapies, absolutely key to the future. We do need to look after people that have progressive MS and complex symptom management. And we need to make sure and ensure that we have equity and access to all services. So that was just a whistle-stop tour. Thank you for listening. I will stop share and would absolutely love to hand over to Ryan and Simon. I can see you now.
Lovely. Thank you all so much for joining us, and I'm very much a welcome to you all. And we're going to be talking a little bit about a personal insight with MS, but also sort of bolting on some of the bits that have just been talked about so very well by Ruth there as well, about sort of symptoms and everything else. First of all, I want to introduce sort of our organisation to you. So MS UK was established in 1993, and we're here to support anyone affected by MS, whether that's people who are directly affected by MS, whether that's families, allies or professionals. We're here for everybody. So our mission, the thing that we work towards, the driving, the nuts and bolts of our charity is that we are here to support people with MS to live happier and healthier lives. Really simple mission, but we do this by improving the understanding of MS and providing support where it's needed most. And in terms of sort of improving the understanding of MS, Simon and I have been working together extensively for the past couple of years, really. But like last year, in 2024, we delivered awareness sessions to over 1,400 professionals, whether that's professionals from social prescribers or the Department of Work and Pensions or other social care professionals generally. So what we're going to talk a little bit about, some of the things when we were planning this meeting and we were or this session, and we were talking with Ruth about what we wanted to deliver and how it wanted to be. Ruth was throwing a lot of questions at us. Well, what was helpful about that? What was unhelpful? What made the biggest difference? So we want to talk about these aspects of life with MS, from diagnosis and treatment decisions through to sort of interacting with health professionals. And well, what was helpful? What was unhelpful? And what kind of support made the biggest difference? Reflecting over something that Ruth said within her slides around the challenges of invisible symptoms, really. And one of those was those diagnostic difficulties that sat in the middle of that triangle. I don't know if you remember that slide particularly, but it was in there. But for me personally, that really rang true, because nearly all of my symptoms are invisible and have been invisible and are due to potentially smouldering MS. Now, there's many of the relapses and disease activity that I've had has been sort of what's known as below the surface, and has only actually been detected by MRI after the event. And I haven't even necessarily known about some of those things. Some of that stuff have accumulated some symptoms over time, particularly around neuropathy and fatigue, that sort of like feels like it's ever so slowly ramped up over time. But many of the symptoms and issues that I've gained, or many of the relapses that have happened, have been underlying and possibly as a result of smoldering. So yeah, actually, one of the things that was most helpful to me was getting diagnosed in the first place. And I was diagnosed through optic neuritis and popping into an optician and going, I've got a funny little blind spot left of centre of my vision. And then kind of immediately seeing inflammation within my optic nerve, giving me a letter to go to the GP making a referral to neurology making a referral to ophthalmology, CAT scan, MRI, and then I was diagnosed within 3 months. But some of that was around gathering history, because in the previous 2 years to that, and this is some of the things that were particularly unhelpful maybe, was that I'd had lots of symptoms that were of a neurological origin that had been passed off as other things, that have been misdiagnosed. I've been told that the numbness and in my right arm that was likely stress and anxiety. You work for social services, it's a stressful job, so those sort of things, they made a difference, and they're there. So getting diagnosed in the first place, I consider myself really lucky, as weird as that might sound, because I think even now, 16 years later, I think I'd have been going backwards and forwards to the GP with undisclosed symptoms, just like lots of the people that we hear from on the helpline. So I feel like I'm actually kind of quite lucky, and that's made the biggest difference for me in that. And so, Simon, I wondered if you wanted to sort of jump in, if there's anything you wanted to speak about your diagnosis journey.
No, in terms of my diagnosis, I hadn't got a clue that anything was wrong until one day, working a long, long way away from home. I'm standing in the middle of a construction site talking to a colleague. Next thing I know, I'm sitting on the floor, still talking, because that's what I do. But my legs had just completely gone from under me. They got me back to the tea room, and in great builder style, gave me a cup of tea and went, "Come on, mate, what's up?" And I was fine. I stood up, I cracked on with the day. I was a bit tired, and then took myself back to the doctors, and they got terribly excited about heart problems, and then everything else under the sun that you might want to work through during the year it took me to get my diagnosis of, oh, well, it might be a big heart problem. Oh, it might be a brain problem. It might be cancer. It might be this, it might be that. Until finally they put me in front of the right person, who watched me walk down a corridor and went, "We've got to do some more checks, but it's MS. And because of his experience, he was able to see perhaps what others couldn't. And he was very good in that he gave me a chance to talk, a chance to question, and a chance to choose as we went through the whole process. But that is not what I always see with people, because people are rushed and people are often confused about what the diagnosis might mean. Just one small thing from the earlier slides was the picture of smoking being a bad thing. When I heard about MS, I thought, oh, well, that's it. I'm going to die within the year. God knows what it's all about. Thank God I can start smoking again, because I gave up 30 years ago, and I thought, oh, well, I might as well smoke for the last few months of my life. At which point my consultant very sensibly told me where to get off and explained that it was a really silly thing to do. So, yeah, and I'm still here 10 years later, not smoking. Anyway, so that's my diagnosis journey.
Well, thanks, Simon. And was there anything within that that was sort of like in the way that you were approached by healthcare professionals that was like particularly helpful or unhelpful even?
I think for me in particular, the two things that really stand out were a number of people who were willing to say to me, because I needed it, that yes, you are ill. I was very much in the attitude of, I can fix this. I've got control of it. And you have to learn that actually you can have some control, but you're not the boss of it all. Then on the other front, perhaps meaning to be helpful, but it ended up being unhelpful, was an early piece of advice from an MS nurse that whilst I was still up and walking about with a walking stick, you don't really want to go to that MS gym, because there's a lot of people there that are very, very much more disabled than you, and you'll find it depressing. I think it was meant from kindness, but it was wildly different from my experience. People in there understood what I was going through. They might be using a wheelchair, they might be wobbling about, they might be using a walker, or they might be, in a number of cases, running marathons, which I've never done, never intend to do. But the wide range of different people made a huge difference to me. And as I say, unhelpful, but meaning, they were meaning right, but it wasn't the right thing for me.
That's interesting. Thank you, Simon. And it's in terms of that, it's almost like they were saying seeing people who with more advanced MS was going to be sort of challenging for you. Well, in actual fact, that sort of feels like what we'd rather have from people is to make it very explicit that everybody's MS is totally different. It's one of those very early lessons that people need to learn, and that's very much something that kind of I had as a turning point in my journey with MS. In terms of treatment decisions and stuff that's presented to us along our journey with MS, I'm on my third disease modifying therapy now over my time with MS. Some of those things and the treatment decisions that have been there that have made a real difference is the choices that have been presented to me along the way. Some of those things have been able to be, some of those things have been better supported than others. When I was initially diagnosed, there were only 5 disease modifying therapies available to people with MS, and then only to people with relapsing remitting MS. It's only been in recent years that we've had some drugs that have been available for people with more progressive forms of MS, but back then there was only 5. and that choice was sort of presented to me. There's some leaflets, go away and have a look. There wasn't not much there. Now, it must be said, and one of the things that really makes a difference is the plethora of information that's out there. So most recently, it was found that I had some underlying disease activity as a result of a monitoring MRI. I hadn't noticed it physically. That I didn't know that there was anything going there, and as a result, that prompted the fact that I could escalate my treatment if I chose to, and I was presented with some choices by my team, by my MS nurse and my neuro, and I was able to go away, look at MS Decisions, look at the Clinic Speak website. That's a comparison tool for kind of a tool that's been developed by I think UCLH and Barts. The Royal, but it makes a comparison tool for looking at all the disease modifying therapies and helps you make a choice that we've given some lifestyle interventions. But my team had talked me through some of that stuff, but had also given me some personal wise words in terms of my neuro being able to sort of talk me through how to make some of those choices. Because even 10 years later, I find myself feeling newly diagnosed when I have to make those choices all over again. 16 years later, I should say, from diagnosis that's in there. In terms of like life with MS, and what can be helpful and what can't be helpful for me personally, the biggest thing that's made a difference to me was actually, well, it's almost both of the things. An unhelpful thing was getting referred to neuropsychology and being told there's an 18-month waiting list for it. However, that turned into something helpful because to try and get that waiting list down, the team had taken on a locum psychologist who was able to offer cognitive behavioural therapy. Now, I can honestly say that in terms of any kind of therapeutic input and all the things that were there that have been offered, that has been the one thing that has made a lasting difference to me in terms of being able to continue to live, a bit like Simon said at the beginning, live alongside my MS. And as it changes, I've been able to reframe various different coping strategies and the way I think about things. And that has been one of the most powerful tools. But the thing that has made the biggest difference overall to me in terms of living well with a long-term condition like MS was something that Ruth talked a bit about earlier on, and that was the MS Brain Health Initiative. And when Professor Giovannoni and his colleagues originally made the MS Brain Health report, there was a guide this is a consensus report that seeks an international consensus from clinicians across the world, actually. But what it also had was a guide for people living with MS. And some of the things that Ruth talked about earlier, those 6 ways to improve brain health, about keeping active, about keeping your weight under control, about keeping your mind active and keeping yourself cognitively stimulated to prevent sort of like brain atrophy and loss, avoiding smoking and controlling alcohol intake. Those 6 bullet points, although it's not exactly a lifestyle program, the fact that there was so much evidence base behind all of those gave me some achievable goals and stuff to work towards. And that made a real big difference in terms of feeling in control as you possibly can of your condition. And Simon, how about yourself with life with MS? Is there anything that you can add to that?
I think I would say that community makes a huge difference for us all. But I would agree with, well, everything you've just said. Personally, CBT, yeah, no, but ACT is the thing that worked for me. Again, because simply it's quite a direct approach to giving you a nudge to do the right thing, and I always need a nudge to do the right thing.
And so ACT, that's acceptance and commitment therapy. So another type of talking therapy that's particularly with kind of acceptance in mind, and that has been sort of shown in various studies to be something that's pretty successful for people with MS. We've had an introductory session that's available via our online portal for that. Now, when it comes to symptom management and symptom monitoring and reporting, I'm really pleased to hear what Ruth said earlier on there, because one of the things for me that was the most empowering and that made the biggest difference was being told what's used, what's going through your mind in terms of your assessment of a relapse. What do I need to do to aid you in terms of getting me steroids the quickest, if that's the right route, and everything else. And a lot of those things was around reporting, was around keeping a symptom diary or a symptom checker. It was around and the biggest difference that's made, and I was coached very much by an early MS nurse that I work with around how to do this, but it was fostering a good relationship with my GP, so that they knew when I got in touch with them and said, I think I'm having a relapse, but I need to be screened for infection, that they would get me in for a urine dab test, that they would possibly get me in for a blood test or whatever might be needed to rule out any kind of physical infection before suspecting I had a relapse. And so fostering that good relationship and being equipped to go back to you as my MS team to be saying, look, here's these details, and I don't think it's an infection because of this, that was very, very important for me. And for Simon, how about yourself? As things have changed for you this year somewhat, how are you feeling about symptom management?
I think what I have taken from it over the last few years, to be honest, I've had a series of maybe once a year a significant relapse, and every year it becomes a new thing to face. I am now a permanent wheelchair user, which I wasn't last year. Last year I was using crutches, which I wasn't doing the year before, etc., etc. And that, like Ryan says, it's a new diagnosis in terms of being able to cope with it and face it and address it. When I was first diagnosed, I was walking 20 plus miles every day that I could, and I was able to do it easily. When you suddenly find your life physically limited, it means you have to readdress everything, and you need people on your team who get it, who really understand that it's a ever-changing condition.
Oh, thank you, Simon. No, that's a really good insight. And in actual fact, that's what it sometimes feels like to me in terms of my coping strategies and what have you. It feels a bit like that suddenly my coping strategies, which have been a solid foundation that had seen me through life and all the challenges that life were there, it's almost like I suddenly had like emotional subsidence. Do you know what I mean? And actually my foundations were suddenly rocky to all my coping strategies. And that's cognitive behavioural therapy helped me to revisit that, and in terms of looking after my mental health and my emotional well-being, they were discussions that hadn't really happened so much with my MS health team, I think because I was presenting as so bright and so capable of looking into things. But I would prompt people to sort of always check in, because mental health can be a very still have a stigma attached to it, unfortunately. And in terms of that, the social supports that were talked about, Simon's really sort of mentioned around kind of having people around who can get it, that can make a real difference. Well, that sort of would lead me on to a little bit of what I'm going to talk about next in terms of the importance of peer supports. So peer supports are basically encouraging peer support is something that we really want to do, because in just before the pandemic in 2019, we did a huge piece of work in talking to the MS community, and it really came through as a strong message that people with MS at all stages of their MS journey, all people with MS who came back, I think it was something like 70, close to 70% of people expressed that they'd experienced issues relating to loneliness and isolation, even when they were surrounded by friends and family, because they were surrounded by people who didn't get it. And that in terms of engaging with professionals, whether that was counsellors or other professionals, they found that they didn't get They didn't get benefit from it when they didn't believe that the person giving support really understood their condition. And got where they were coming from. But peer support can improve self-efficacy and encourage like less reliance on statutory services, right? So that's across the board. And peer support can reduce loneliness and isolation issues and increase connectedness and general well-being. So as Ruth mentioned earlier on, there's a range of different options that are available that are MS specific. So we have our peer pods, small Zoom groups that meet regularly throughout. There's ones on creative writing, there's ones that are just for women, there's ones that are that's around MS and work. There's all sorts of different things that tie in with that. The MS Society has a befriending service, the Shift MS Buddy Network, and of course there's the neurotherapy centres dotted up and down the country. As well as those, there is also existing support within your community from people like social prescribers who are there to reduce loneliness and isolation, or to support people to reduce loneliness and isolation too. So I just really wanted to make sure that we'd sort of chatted through some of those things too. Now, in terms of like our MS nurses and interacting with health professionals, is there anything else, Simon, that you feel you wanted to add to that before we finish up?
You've covered so much. I'm sure there was. It's gone completely from my mind. I didn't write that bit down.
No, but that's okay. That's okay, yeah. Simon, that's fine. I mean, I think that I think we've covered it, and we've talked about a lot of the things that are helpful for us, and the things that have worked really well and what haven't worked. One of the things I wanted to sort of talk a little bit about as we finish off, is about what do we do? What's the rest of our organisation do? So we have a helpline, so that is available. We have a web chat via the website. There's a free phone number. You can get us via WhatsApp. We're 10 to 4 Monday to Friday. We have a New Pathways magazine, which is very much a lifestyle magazine rather than a charity newsletter as such. It's largely written by people with MS for people with MS. We have our online services, which include our peer support service, but as well as that, our sort of our supported exercise program with a level 4 exercise professional experienced in neurological conditions, and he pitches classes for people who are seated but without core strength, seated but with core strength, and then standing either aided or unaided. So there's something for everybody across here, and your local MS Society and your neurotherapy centres. There will be likely to be support in your community. We do our choices booklets. This is online content and physical copies as well, which you're very welcome to order for your clinics. We have web-based information on benefits, MS and work, preparing for the future, all sorts of different things. We also do our MS awareness training and our e-learning. Now, our e-learning, we have that CPD accredited, and we have an e-learning course that is counselling people with multiple sclerosis. And we also hold a directory of MS counsellors who list their experience on there too. So just as we wrap up then, thinking about what we'd like to see from the future of MS nursing. Now, going back to what Ruth was saying and tidying up at the end, I'm glad to see that there's some crossover with what we've said here and what we think that is generally sort of needed, what we'd love to see more of. Some of that is about that equitable access to care, and making sure that the postcode lottery is removed as much as possible. But what we'd love to see is some more advanced MS nurses everywhere, because this has been a fantastic initiative by the MS Trust to bring into play more MS nurses that are MS nurses plus. I think I'm right in saying that have an extra skill set that really can support people with those advanced MS needs. And you know, I'd love to see more of those across the country as well if we could. And in terms of collaborative care approaches, I think Ruth talked very well about kind of how that works from a quite a technical aspect, but I also think in working with peers and what have you, but I also want, I'd love to see MS nurses being those exemplars in that shared decision making and treating people with MS as partners in their own care. And would also like to see making the most of technology, but without losing the human touch. And perhaps some of those wearables and monitoring sort of fall into that category, I think. I'd also like to encourage people to promote that self-management, all those things that Ruth was talking about. There was a great course that the MS Academy put on that was around supported self-management. There's Professor Giovannoni has just published through his MS Selfie Substack newsletter a self-management guide to. There's so much information and so much support that's out there for people to look after themselves, to monitor their own MS as much as is practicable, and to live just as well as they can. That we'd really like for you all to be promoting that self-management, really. Well, I think that is the end of me and what I'm sort of have to sort of say there. But I hope I haven't rattled on too much, and I can stop sharing.
Thank you so much, Ryan and Simon. And actually, if it's okay, I would like to just come back to you. I think one of the things that we struggle sometimes as MS nurses, and maybe it's across the team, is you've talked a lot about the support that's available and the importance of social connection, but sometimes the people that we are looking after either have, as we've mentioned, cognitive impairment or some mood disorder, and that affects their ability or wish or engagement outside of the home, and maybe they live on their home, all of the situations that we're aware of. I don't know if you have any suggestions or kind of, I don't know, just thoughts around that you could share with us about how we could do that better.
Well, Ruth, I think that it's about engaging perhaps sometimes even outside of our initial sort of like multiple sclerosis family, if you like. Do you know what I mean? One of the things that we've been doing is targeting the social prescribers, because social prescribers are part of the government's universal offering of kind of care and support, and they're available for anybody who's got a support need. And what we're finding is that because they're universally out there, and one of their big aims is about reducing loneliness and isolation and increasing that connectedness within long-term conditions, sort of like groups, that they're kind of getting some of that stuff right, boots on the ground, introducing people to, I don't know, like somebody I spoke to recently was introduced to a well-being, gardening for well-being type of program with raised flower beds and an allotment where there was produce to come away from. And some of that was not condition specific, but it was exactly doing that, reducing the loneliness and isolation, but also being introduced to it by a professional who understood the condition. Does that make sense?
Yeah, absolutely. Simon, do you want to chip in?
Yeah, all I was going to say was, I think as people learn about their own MS, they will come across any number of people that they could talk to, but won't want to speak to all of them. Everybody's different. Everybody's reaction to the type of conversation is different. So just because one solution doesn't work, make sure that they get to see another solution. They might not want to sit in a group of people and talk about shenanigans, but on the other hand, they might want to have a one-to-one conversation about something that's troubling them. And there are many different ways to, get through to a helpline or a befriending service that can solve that for that person. Just recently, I've just had it was about an hour and 40 with one person, one-to-one. They're facing HSCT and they're frankly terrified. And there's not a lot you can do about the fact that it's frankly terrifying, but you can have you can listen to what they've got to say, and you can allow them to open up. And by allowing them to open up, they might be able to open up to other people as well. And that's all that we can do, really.
Yeah, thank you, Simon.
There was one other note that I made down here as well, Ruth, if you don't mind, just while we're going up there.
Yeah.
It was something about your where you were talking about like in terms of a hidden condition, and you were talking about how MS makes people feel nervous, and or it was the slide that you talked about where people were not disclosing their condition, essentially, and what have you. And how talking about MS made people feel nervous and they didn't know how to explain it properly. And there was a good chunk of that. And I think some of that is around kind of people developing a health literacy, which you don't always generally have. Do you know what I mean? We're terrible at it here in this country anyway. We're always talking about being poorly or being ill, but not really giving names to things. Do you know what I mean? Or just being quite specific. So there is quite a lot of stigma attached to some of that stuff, but also just that actually promoting that health literacy so that those conversations can be had without stigma. And some of that comes from that early contact with your MS team and what have you, but also just knowing what resources are out there. I think that Shift.ms does that really, really well with their set of videos that they have, for instance. I think that they're fantastic. They just help to be able to start you by equipping you to have that dialogue. Do you know what I mean? Have those beginning bits of a conversation if they're particularly difficult.
Yeah, absolutely. Thank you. Sorry, Simon.
I'm going to jump back in as well now. Just one thing. Please encourage all the nurses to say that when you've got an appointment with a consultant, write all your questions down before you go. I know that's probably quite a general thing. Probably everybody ought to do it to everybody, but we all terribly when that glorious consultant's in the room, we all become slightly dumbfounded and forget all the important things that we meant to ask, or we'll talk about the one thing that's really irritating us today, and not the thing that means that we don't get a good night's sleep. So write everything down is a really important thing for people to do.
I would absolutely reiterate that. And actually, I do advise people is to take a notebook with you into clinic and get it out, put it on your lap so that the person that you're seeing knows that you have a question. And then you can have an agreement because it's around your agenda and the clinician agenda. And it's both are obviously completely important. Just to let you know, HSCT stands for hematopoietic stem cell treatment. So do look that up online. It's one of the treatments for MS and pretty exciting. Just before I come to Sarah, I want to ask you one of the questions that's in the chat. But Ryan, someone's just asked if you could just clarify a little bit more around the social prescribing that you mentioned. I do think it's something quite new and a bit confusing for all of us. I don't know if you have more info about how people can get in touch with their local social prescriber.
Absolutely, more than happy to do that. There will be a social prescriber attached to just about every GP practice that exists. So social prescribing came around because they were finding that was an awful lot of people were presenting to their GP with issues that were social in origin. Do you know what I mean? That weren't necessarily. It was around loneliness and isolation, for instance, or what have you, or that was the root cause behind the depression that they were presenting with, for instance. So they started off some pilot schemes which were successful, and it's been rolled out, and it's become quite a lot and it's a scheme that's available everywhere. And like I say, it's at the forefront of the government's offering for health and social care, like person-centered health and social care, really. And a social prescriber would be a link person, a link worker, or a community connector, or something like this, a name to that effect. And they should be getting to know what the individual likes and dislikes and what their goals are, meeting people, joining a club, getting condition-specific support, for instance, and then they would map out that support within the community. So they would have boots on the ground knowledge, and they may even have some existing groups like that gardening for well-being scheme that exists that they can help people to join, or well-being walks, or some of these things that are very accessible and out there within the heart of each and every community.
Thanks, Ryan. These are absolutely key, aren't they, to supporting people to self-manage. Sarah, I wondered if I could just ask you, someone's popped a question in around the link between the Epstein-Barr virus and MS. I know it's a pretty exciting discussion at the moment.
Yeah, no one knows the exact link. Gavin Giannoni has done lots of work into it. There's certainly a very strong link, but it possibly is more to do with some genetic susceptibility, because lots of people are EBV positive. If you've had mononucleosis or kissing disease, whatever you want to call it, you've had EBV. So no one knows exactly, but they are doing a lot of work to see if, if they could vaccinate against it, could we prevent MS? So Gavin is the man to follow on that.
Thanks, Sarah. And yes, you're absolutely right. There's a lot of strong evidence, isn't there? It's quite exciting. I don't know if you want to, I know you've put something in the chat, but just the question around Africans, and I'm from Kenya, so it's been quite an interest, but I just wondered if you wanted to touch on that. I know the
Well,
question is, why do
yeah,
people suffer from it?
I mean, MS is prevalent all over the world. The bit about the Vikings was because they were in Scotland, and that might be why Scotland has a higher prevalence of it. We know that as people move away from the equator, your vitamin D levels get lower, and that tends to be linked with MS as well. Lots of people have very, very low levels of vitamin D. The exact link, like with EBV, no one knows. We do know that environment has got lots into play with it. So if you're African and you born in Kenya, say, but you move to the UK as a child, you then take on the UK risk. It's because you're exposed to the environment here, processed foods, all those kind of things, everything that we think may play into it. But again, I can't give you an exact answer because nobody knows.
The only thing I'd add to that is that I think historically it used to be considered rare, but most of that was because we had a lack of awareness. Diagnosis rates were quite low. I think they are increasing. They don't have access, so there's underreporting and misdiagnosis. They don't really have as much access to neurologists and diagnostic tools. But as I've said, this is absolutely changing. And I think, again, within the world of MS, there's much more international collaboration, which is key to supporting people. And again, I think that's probably the same from the charity side, that actually they have, because of the networking and the word that I'm not going to mention over the last few years, there's been a lot more international collaboration between not just healthcare professionals, people with MS and charities. And I think that probably is hopefully benefiting people in other countries. I don't know, Jonathan, whether you wanted to comment just kind of in kind of reaching the end of the webinar, just kind of your thoughts around, being able to have this kind of conversation and the importance of bringing together this webinar and the importance of these collaborative pieces of education.
I think this is just an excellent demonstration of how we can all work together to improve our knowledge and shared understanding. I think it's invaluable having Ryan and Simon here sharing their lived experience of living with MS and hearing it from their perspective. Something that I think has really struck me is how individual someone's MS experience can be, and we need to really make sure that we're listening to the person and working with them about what works for them, what's their MS experience like. But yeah, in times when finances are hard and services are being cut and we're all pressured, we tend to look at our own workload, don't we, and focus on ourselves a lot. But we get so much more done when we reach out and work with others. It's been enlightening for me as someone with very little experience of MS, so I found it invaluable listening to you all speak today. Thank you.
Thank you, Jonathan. I think that's absolutely key. And if you do have questions or thoughts or comments, please put that on your feedback at the end of the webinar, because we are looking at what we could do next for the next webinar. We're very conscious of the fact there's been a huge amount of information. And I just want to reiterate your comments there, Jonathan. Thank you so much to our speakers. Thank you, Ryan. Thank you, Simon. Thank you, Sarah and Jonathan, for your time today. I think it's been a kind of partly whistle-stop tour, but it's been very informative and hugely interesting and completely from the heart. And I really appreciate your time. Thank you very much. And thank you to our attendees for being here and for joining us for this session. Thank you, everybody. Enjoy your evening.